All right. Hello and welcome everyone to session one of the Completed Life March Symposium. My name is Sarah Cascaden-Bechtel. I am the program director at the Completed Life Initiative, and I will be your host today as we explore the topic of suffering in the context of serious illness. Today, I have the honor of introducing Dr. BJ Miller as our keynote speaker and Dr. Paul Menzel as our interviewer. BJ Miller, MD, speaks internationally on the themes of living well in the face of illness and death. He has practiced and taught in all major settings: home, hospital, clinic, and residential care facilities. In his work, he draws upon personal experiences with disability and his undergraduate studies in art history as much as his medical education. He has been profiled in the New York Times, interviewed by Oprah Winfrey, Tim Ferriss, and Krista Tippett, and co-authored the book, A Beginner's Guide to the End, published by Simon & Schuster in 2019. Dr. Miller is the president and co-founder of Mental Health in the San Francisco Bay Area. Joining Dr. BJ Miller in conversation today is our interviewer, Dr. Paul Menzel, Professor Emeritus at Pacific Lutheran University and esteemed advisory board member of the Completed Life Initiative. Welcome, Paul. Welcome, BJ. It's an incredible honor and privilege to have you both here today, and welcome again to the audience. We welcome your questions in the text chat or the Q&A box on the side of your screen at any time, and we'll get to them as soon as we can. Without further ado, I will turn it over to Dr. BJ Miller for his keynote presentation today.
Thank you, Sarah. Good morning. Hi, Paul. Good morning, everybody out there. Pleasure to be here. So I thought I'd kind of get us started, warmed up with some slides. They are really meant to be just sort of placeholders, guys, or not placeholders as much as sort of tips of icebergs to get us thinking and get us feeling and thinking about this big subject, because there's just so much to talk about. So I kind of want to get us in the ballpark. First of all, thanks to the Sarah and the Completed Life Institute for bringing me into this at all. It's such a pleasure to be with you, Paul. I love conversations like this, so thank you, guys. So I'll start here. This is just a painting by Francis Bacon that on some mornings could be a self-portrait for many of us. I think we all, especially these days, may have felt stretched in ways that almost begin to distort us. And certainly our patients and their families and illness can do this too. So next slide, please, Sarah. So I want to ground us. Forgive me, a lot of you guys probably know what palliative care is, but I almost always start with a slide like this because palliative care is just so poorly understood, even within healthcare. So let me just start here, guys. There are several definitions of the field out in the world. And I mention this both because to note with the professional lens to which I'm approaching this subject, but I also want to note too, as you guys think of questions and comments, and hopefully Paul and I will, in our conversation, will open up things where, the boundary between personal and professional in this work can get blurry, almost necessarily blurry, if we're really in it together. But I want to sort of start here to show a little bit about my bias per se, like where I'm coming from, but also to remind us what this field's all about. So I'll just let you guys read it. Okay, I mean, we don't need to belabor this. In fact, we can't. There's too much to say, so we won't say too much. But I think one of the things to note here about this field and why it's unique in medicine is that it revolves around the experience of suffering, or quality of life, you might say, in the positive, both of which are completely subjective notions. I don't get to tell my patients if they're suffering. They have to tell me that. There's no test for it. Unfortunately, we all we all have access to this notion of suffering. It is a sort of a basic human experience. And that's really key. So the fact that we're embracing the subjective, and also the fact that we're embracing sort of a fulcrum of work that affects 100% of human beings is really, really key. We can contrast that with other fields in medicine, for example. Cardiology, is focused on one body part, or think about how many cardiothoracic surgeons or neurosurgeons have actually had their brains operated on or their chest cracked open. Very few. So in medicine, it's possible to devote your professional life to something that you never experience. Whereas in palliative care and palliative medicine, that is turned on its ear. We are working in subject matter that we all have access to, and that affects the conversation in multiple ways. So I'll just leave it at that. Next slide, please, Sarah. So now I'm going to have to, yeah, that's good. Ooh, you were there. There we are. So I'm going to try to watch myself because I can go on and on these slides. So I'm going to remind myself of what I said to you guys, which is these are meant to be tips of icebergs, not big full-on conversations, conversation starters. So this slide for me is just a placeholder around how medicine went the way it did. Again, as part of the context and backdrop for a lot of our experiences towards the end of life. In medicine, this is a painting by William Prosperi called Ether Day, which is a moment in 1846 when ether was harnessed, put a person to sleep, and they could operate on them. This is the beginning of anesthesia. And hey, great. Thank goodness for anesthesia. I love this stuff. I've had multiple surgeries. I much prefer anesthetic to a vodka and a stick. So great. But as this sort of kicked off a 170-year sort of fever pitch around technology, that we were going to invent our way through every problem, use sort of medical knowledge and know-how and ingenuity. And, fair enough, we've done a lot of work with that. A lot of good has come from this sort of scientific method. But you can see, even in this picture, the reason I love this picture is, in a way, the person's out of the way. And you get this sense being a patient, that your experience as an individual, as a patient, your perks, your personality, et cetera, are almost sort of in the way. And ideally, it's sort of like you separate the personality from the body is almost medicine's sort of highest goal. That's not fair, but it can feel that way. So I think a lot of good has come from this kind of approach to care, but also what we've done is we've taken away, we've invented spectacular ways to sort of take us apart and specialize into ever fewer slighter body parts or conditions, but we have lost the art of putting ourselves back together again. And that's really on us as individuals, as human beings, not so much as physicians these days. Okay, so you get the point of the healthcare system. I'll try to get off that soapbox now. But next slide, please, Sarah. So here, guys, so these are sort of lessons drawn from this kind of work, and distinctions and contrasts for sort of normal care versus this type of care that we're interested in here today. So one would be the distinction between curing and healing. Curing is beautiful, amazing. When it's possible, I'm all for it. But it's just not always possible. And for all of us, eventually, it's not possible. So we need to find ways to care beyond the cure moment. We should almost probably never hear ourselves say in healthcare, there's nothing more we can do. There may be nothing more we can do to fix a problem, but there's always more we can do as human beings to accompany one another as we stare into the abyss, as we come up against things that we can't change. That's so much a part of the human experience that otherwise can get carved out. And can we end up making each other feel even lonelier than we need to be. Whereas the goal of healing, that is the idea of being whole. Now that's a bigger, better goal. That is probably always possible. I've worked with a lot of patients who are dying and their final breaths are whole, are healed in that way. I, as a disabled person, I lost my limbs, or 3 of them anyway, in college. It took some time, but I became whole again. So even when we're not fixable, we may be healable. So I think that's a much better target for our work. Next slide, please, Sarah. Here too, the healthcare experience and a lot of the way we've come to think in modern life is our transactional, one moment at a time, so often disconnected. We kind of ping around. It's true in the healthcare system in particular. Our acute care settings, hospitals, we have lots of them. They're big, they're shiny, they do amazing things. We don't do so well when acute issues become chronic issues. And what's the difference? I mean, it's in the name there. It's in the word chronos, time. So acute care can get away with sort of a transactional approach, whereas chronic care plays out over time and becomes experiential, much more so. And so it begs a different skill set for those of us doing the work, and from those of us receiving the work, also it has a sort of different set of needs that go with chronic care. We're not so good at that in that country in the shows. I think we sort of abandon each other. We see cure as the goal. We see incurability as something of a failure. And it shows. The way we allocate resources and attention in our training in the medical world sort of reflects this bias. We're trying to sort of right this ship in palliative care. Next slide, please. Real quick on this one, I just wanted to call out sort of the failings of a medical model, sort of to pathologize every human experience. It's an interesting convention and it has some utility, but what ends up doing, we keep framing everybody's issues as problems, again, to be fixed, or at least calling them problems or pathological. And then our goal is really to make things less horrible, less pathological, less bad. Okay, fine to some degree as a convention, but life doesn't really work that way. And if we sort of isolate ourselves from things that go wrong, and if we kind of keep a lens of trying to at best reapproximate some idea of health where we have perfect blood pressure, perfect lipids, all our body parts, etc. If we define our experience by what we're lacking, then we're never going to really get to the full-throated experience of humanity, which is life is amazing, life is awesome, life is unfathomable, life is unbearable too. But so I just want to lift our gaze beyond pathology and the medical model to where life is bigger. And so maybe we can hold both goals of making life less painful as well as more horrible. Next slide, please. This is just a note to this work kind of always begs me to think about intuition and gut sense and nonverbal communication with ourselves and between each other and internally with ourselves. So the word gets a lot of power in medicine and the rest of life, but I just want to draw attention to the wordless place too. That's where so much of the action ends up being. Next slide. Here, just to note that death, end of life, illness too, brings us in mind of the body. And the body is an amazing thing. And one of the things that the body does is it feels things, it senses life. So I really want to see this word more and more in our sort of models of care, is that this is the aesthetic life is just the life of the senses. It doesn't need to be pretty or pleasant even. It's just a sensation of feeling. And when I came close to death myself, as I kind of re-entered the life of living in daily life, I became much more attuned with my aesthetic life, my aesthetic experience, how I'm feeling, literally feeling, sensing my life. And I think this is where a lot of poignancy is. And if we're not careful, the typical healthcare experience can crowd out the aesthetic domain. There are a few places that more brutally assault the senses than a hospital. Next slide, please. Here too, just want to call out, we are meaning-driven beasts, and there's something very powerful about that drive in us. We humans can find meaning or can make meaning of just about anything. And it gives us a why. If we find why, we have a purpose, we know why we're doing something. There are a lot of quotes, Nietzsche, Frank, a lot of people say something along the lines, give me a why and I can do just about anything, or I can withstand any pain if I know why I have to. So meaning is a very powerful force and needs to be part of the purview of any institution considering itself related to health or well-being. So great. But I also just want to make a plug for meaninglessness. There are plenty of moments, especially along the arc of illness, where you just can't find meaning. It may be there, but it may be wholly inaccessible. And I want to say that that's okay. I want to make space for that too. I don't know the meaning of a sensation. The aesthetic life puts me in a meaningless place. Or rather, the sensation has a meaning all of its own. Art for art's sake, life for life's sake. that there's value beyond our ability to string together a narrative of meaning. Next slide, please. And this slide's not a mistake. This is just my placeholder for mystery. Another thing, if we're going to be walking each other to the end of our horizons, we better have some relationship to mystery and not knowing. I appreciate all our efforts to study more, work harder, learn more, but I think we also have to acknowledge the limitations of our knowledge. Otherwise, we're just arrogant and inaccurate. And sometimes we in healthcare can come off that way. I think we need to find ways, a language for mystery and not knowing, other than words like ignorance. Next slide. Okay, so this is a little 3-slide show, real quick, guys. This first one, just to make the point of a lot of the work we do together, especially towards the end of life, is when we can't change so much of what we're looking at. Well, we can change how we look at it. That's where so much of the action is. Perspective. So this slide is just simply us looking down on Earth as a single object, right? Here we are, one. We are all one. You can clearly see it. There it is. It's this one thing, and we are all of it. Next slide, please, Sarah. Or we can zoom out. We humans can do this. We can zoom out, change our frame of reference, and see ourselves as one of a zillion, one of many. Or we can zoom in. Next slide, please. Here are little virus particles. So we can zoom in and see, and we are, as an individual, my body is a universe for billions and trillions of little critters. That's also true. So my point here is all 3 of these slides point to a truth. They're all accurate, but the nature of the message changes depending on where we place our frame of reference. And so much of the work I find myself doing with people or with myself is when I can't change something, I can change how I see it. I can play with the framing of it so that I or some issue belongs in the frame, and we don't need to be isolated from our own realities. Perspective is the way we do this. Next slide, please. Here's just a quick placeholder, and maybe Paul and I will get into this more, but this is a placeholder really for the power of bearing witness. And I don't think there's a bigger job that we humans have with each other, especially as we head towards the end of life, but to see each other for all that we are, to actually see each other, not squint, not wish parts of the picture out, but simply see each other and accept that. But pause before we heap on the judgments, the values, the evaluation rather. So yes, discernment. Let's be careful with the judgments. That's one, I think, the kindest things we can do. In a frame, in a word, this is bearing witness. Next frame, please. Next slide. Power of impossibility. Sometimes there's relief in things that are impossible. When something's truly impossible, that means I'm innocent. If it's just not possible to be done, then I don't have to hate myself for not figuring out how to do it. If something's possible, then I got to marshal my energy and quickly figure out a way to do it, especially on behalf of my patients. But sometimes we get ourselves in this theater where we're calling impossible things possible, ostensibly because we don't want to dash hopes or whatever else. But in fact, there's actually a majesty in impossibility. There's an innocence in it. Maybe you've had this experience in your life where just don't give me any options. I'll deal with the truth. Don't gum it up with false options and false choices. Let the impossible be impossible. Next slide, please. Here too, I guess I just want to make the point that we humans find all sorts of ways to separate ourselves from each other, to distinguish ourselves from each other, to contrast ourselves from each other. And in some ways, certainly we are. But in a big frame, we are much the same. We all are born, we try to make a life, we die. So when you hear yourself saying, I think about, or the dying, that's a little rhetorical trick of separation. The dying, the homeless, the poor, these are ways we separate ourselves. You may care about the dying, but when you say the dying, you're sort of suggesting you're not dying. The truth is, of course, we all are. This is a camp, this is a boat in which we all belong. Next slide. Myth of independence, just almost done here, guys, but with these. But the myth of independence is another sort of tip of a big iceberg. What happens with illness, and as we head into the end of life, we realize how much we need one another. And there's so much poignancy in that, and so much truth in that. And you come to realize that this idea, this zest for independence, especially in the West, is it's an aspiration, but it's another impossibility. I don't believe there's a human being that's ever walked this earth who needs nothing from no one. That would be a very boring lot if you somehow got there. So when we say I want to be independent or I'm afraid to lose my independence, we should note the little asterisk that we're all on this spectrum between dependence and independence all of our lives, all the time. And when I became disabled, or as when you get sick, you may become a little more dependent, a little less independent, but you're not leaving one world and joining another. It's the same world. It's the same spectrum. We are all on it. Next slide, please. Grief is good. I'll just leave it at that. I've learned the hard way that grief is actually essential and can't be sidestepped. And thank God, it is a metabolic process by which we realize we honor what we have lost and enter into an internal relationship with that loss. And we acknowledge what we still have to work with in this life. And that takes time and that takes process. And that process is grief. And I'm very grateful for it. Last slide, please. Real quick, Et in Arcadia Ego. This is a Nicolas Poussin painting from the 17th century. Et in Arcadia Ego. That's the inscription on the sarcophagus. And in Latin, that means I too exist in paradise. I too dwell in paradise. And it's an active tense. It's not that I was here. This is not a memorial. I am here. And you could read this as a nod to spirit, or in a sort of a Judeo-Christian sense. Or for me, it's simply just a reminder that even within paradise, that even within life, death is part of the picture, right? Death is not this thing that robs us of life. Death is part of life, right? Pain is not antagonistic to happiness. It's part of how we experience happiness. These things are related, not separate. And so much of the work of dying and dying well is finding our way back to wholeness and not a disintegrated life. And one of the major ways we disintegrate is we separate death from life. So, okay, that's my soapbox. And then there's just one more slide there, Sarah. Yeah, thank you guys. So, sorry I went on a little long, but maybe we can cut over to conversation, Paul, and we can hear questions too.
Thank you, BJ. What I appreciate perhaps most about your presentation is all the positive things that you bring out amidst things that so many people think of as negative, whether it be that grief is good or that instead of judging, we just discern and look. And of course, the big claim, which is so true, I think, that death is part of life. And you have a way of approaching and explaining your work in palliative care that emphasizes the positive. There's a lot of wisdom in almost everything you said. And I don't use the word wisdom lightly. It's the ability to discern the things that really matter underneath. And I laud you for that.
Thank you, Paul.
But I also note that the definition of palliative care, even though it has this very positive ring, the original word, I believe, means to ease. But the definition that you started with, that's used in American definitions professionally of what palliative care is the reduction of suffering. So we need to look at what suffering is, which you have discussed, and you have made the point, I believe, that there's no fine line between the negative that is suffering and the positive that can come right along with it. So that palliative care could also be defined as increasing well-being, not just reducing suffering. But if we stick just the suffering, I think there's some real puzzles about what suffering is, and they become really important in certain clinical situations, I think. Is a violation of my autonomy. If I choose, say, to refuse life-saving treatment, not because continuing the treatment would be a very high burden to me in terms of the suffering that I would endure before I die,
Mhm.
but because I think my life is appropriately over and shouldn't go on longer for a variety of reasons. It could be for coming years of severe dementia, for example, or whatever the condition be that I don't want to live on into. If you prevent me from exercising my choice, have you made me suffer? And you, if of course you have made me suffer when you deny my choice, because denial of my choice just is my suffering. I get angry at my liberty, my autonomy being denied, for example. Then you're actually reducing my suffering by letting me have my choice, even if the reason for my choice wasn't at all that I want to avoid suffering. What do we do with that violation of autonomy? Is that suffering?
Well, boy, you bring up a lot of good stuff in there, Paul. I mean, this is juicy stuff. I mean, one thing to note is I don't think of well-being as the absence of suffering. Can you imagine if I think of what my life would have looked like if nothing had gone wrong? I mean, it's a silly exercise. I can't imagine what that would look like, but I am deeply aware of all that I learn and how I'm stretched when I bump up against something that challenges my sense of autonomy, my sense of self, that asks me to define myself. I am usually made bigger by experiences of suffering because I'm asked to answer that question for myself. What of me can bend, can accommodate this situation? What of me needs to stay intact, per se? And I think of the Serenity Prayer a lot. I am not a religious person per se, I'm agnostic, but I do think the Serenity Prayer offers us some good guidance, like that we exercise part of our exercising our will, our autonomy, is exercising reason and choice and discernment, and that we can see things. There's a difference between the parts of the experience of life's experience that we can change, that are controllable, and there are parts of our experience which are not. And it really pays to explore that line. And so part of my answer to your question, Paul, is that us we have to kind of why it gets so darn complicated is that suffering, no matter how much we chase it out of the room, still finds a way in for most of us at some point. And secondly, that suffering, as hard as it is an amazing teacher. So those have to those truths have to be brought into the conversation. But to your point about autonomy, this is where I think this comes up in the End of Life Options Act and Death with Dignity laws, that around aid and dying, as you've laid out so nicely, that when a patient, it's their life, their death, their suffering, when I do need, if when called upon, I do need to find a place of deference as their physician to their experience. I am very keen to see where our experiences overlap and intertwine, but I have to be honest that, of course, as much as we are connected as human beings, there is some difference between you and me. And as a physician, I need to bend myself to defer to your experience to the degree I can. So I also honor doctors who can't be with someone or accede to the wish of hastening death. If they can, in good faith and good consciousness, do that, well, they do need to help find another physician who can help with that. I think that second part of the sentence is very key in navigating the sort of the boundaries and limits of healthcare in this way.
One of the situations where this question of is a violation of autonomy itself making the person suffer, I think, in fact, sometimes it's not. It's a different kind of offense, but you're not making the person suffer and denying them their choice. One place it comes out is when a person isn't suffering, but their autonomy might be violated. And, one example is a person going into severe dementia. Severe dementia is often, not always, to be sure. Sometimes severe dementia can still involve distress and clearly in behavioral terms, what we would think of as suffering. But in other cases, the cognitive capacity of the person is low enough that they don't have the capacity to be distressed by their inability to remember things, for example, etc. And I don't want to romanticize this at all, but in some certain real sense, they appear to be among the happy or at least contented demented. Now, if they wrote an advance directive which said very clearly, suppose it's an immaculate, it covered exact conditions and when, and they designated the interpretation of that to their proxy, their designated agent. The time had come very clearly, given their advance directive, when they should either not be given an antibiotic for pneumonia if they got it, to take the holding of a life-saving treatment, or that they be that manually assisted feeding, which they would need likely at that time, they wouldn't be able to self-feed, should be withheld. And they wrote that directive not because they thought they were going to be suffering at the time and that the food should be withheld or the antibiotics should be withheld because they would be suffering. They wrote that directive because they just did not want their life to end with 3 or 4 years of severe dementia, which can easily happen if the life-saving treatment isn't withheld or the assisted feeding continues to go on for years.
Yeah.
Some physicians I know have tended to say, well, but they would really be suffering if their autonomy were denied. But they're not suffering. So do you want to interpret the violation of autonomy as suffering? I know physicians are often drawn to, my mission is to reduce suffering. This is sort of palliative care, I think, to the nth degree. But should we expand suffering to include the violation of autonomy? Or should we just say suffering can only go so far in justifying our decisions? And people can make decisions and physicians can follow them or be attentive to them, not because they're reducing suffering by making this decision, but because they're respecting the patient. So how far does the suffering carry you?
So God, this is rich stuff. I think part of the answer here is that autonomy, like independence, is an aspirational extreme. That in my worldview, autonomy, only any of these constructs, they're constructs, will get us so far to sort of noting the full extent of a reality. Autonomy is in tension, of course, with other bioethical principles. Not one principle sort of rules the roost because these are aspirational. So I think it's important to note that autonomy has its limits too. That we are interdependent, we are entwined, we sense one another, we need one another, we experience life in relationship, etc. So I think part of my answer to respond to your question is to really open up the nature of autonomy. But to answer your question, I think the respecting someone's wishes is the meaningful, respectful, that's redundant, is the meaningful therapeutic exchange. Not just, well, hey, it says on your form 3 years ago you wanted to, didn't want to live with dementia, so I'm, hey, it says it on the form, I'm going to offer you. But rather, if we can actually honor the relationship that is required of healing and of healthcare, and we can move with each other over time, we can allow ourselves to have our minds changed too. I mean, the problem with an advance directive, as you lay it out, is a projection into the future. So now, this really hits home for me. So I think a lot of us can realize that we often imagine a situation in the future. The way we imagine it, like death, is very often probably much worse than actually experiencing it. Our imaginations run wild this way. In the disability world, this is a big thing. Like, if someone had asked me, hey, would you have wanted to live with, if I'm going to take 3 of your limbs, would you wanted to keep living? I may have said in the abstract, shit, no, that sounds horrible. I don't know, let me go. But of course, when I'm in those shoes, then the world looked different. I did want to keep going. So if I had had to make that decision years in advance, it probably would have been a different decision. So, yeah.
Absolutely correct. And anybody who's not sensitive to that, even when they write their own directive, they should be sensitive to the fact that what they envision may not be experienced by them then as what they now think they would experience it as.
Right.
I mean, that's just so true. It has this kind of adaptation effect, constructive, really constructive adaptation that we ought to honor, honor indeed. needs to be respected. But in the case of the person entering severe dementia, some people, not all, some people who write these directives write them because they've had intimate experience with their loved ones, parents, sisters, brothers, grandparents, etc., friends, going through this. And they are passionate in their conviction that the arc of their life is not best in terms of the goodness of their life if it's capped by 4 years of severe dementia, in which they're cognitively withering, and enough, that is, that they don't actually suffer at the time. They're aware of all that. So their directive, and they also had said they had great confidence in their proxy, whom they named, to know what they would want to do if, of course, as it always will be the case, the directive isn't exactly precise enough for their caregivers to know exactly when to implement it. So it's paired with a designated proxy, and the proxy says, yes, I know this person well enough, and we've had conversations before the person lost capacity. And it's very clear to me that this is the time to implement it, and yet they're not suffering. Or should we say, well, they are suffering because their advance directive isn't being respected? My own view is perhaps like, I think it's yours, that we shouldn't put all this under the cover of suffering. There's also respect for the person and respect for autonomy that goes with it. And some situations come up where we shouldn't deny the person's choice, whether it was previously stated choice now being implemented by proxy or current choice, because the choice is not motivated by avoiding suffering. You bring that into your world also? And is it part of palliative care? To what extent is respecting the choice of the patient also part of palliative care?
A huge
The
part.
definition is the reduction of suffering.
Yeah, it is. And I also think if you look, the second paragraph of the CMS definition ends on respect for autonomy and choice. So it is part of the mantle of palliative care. But you're right, I do hear us sort of revolving around this axis of suffering. And I'm aware that we rely on a sort of that the word suffering gets people, it's a motivating word, it's an animating word, it gets people, oh, I don't want to suffer. So it has this kind of call to action to it, and it's something that we can sort of, most people have some relationship to the notion, so it's actionable, but I do think we over rely upon it. But to your point, it is a piece of the puzzle. I mean, that's why I like to perforate the lines between life and death. I like to perforate the line between suffering and happiness. They need each other. Suffering is not like, it's not some God that sort of anti-suffering is not this, we're not at a altar. That is a part of the human experience. So it needs to be, it's a relative experience. It needs to be held in relationship to other forces in a life, etc. So I am with you very much, Paul. And I think my field is too. Where I see my field get into trouble is when we're relying in the abstraction, we're relying on our definition or talking about our field away from the bedside when we're trying to kind of transmit concepts. That's where I see our field kind of sclerosed and confused. At the bedside, when I watch palliative care happen, it naturally kind of flows into the zone that you're describing, where suffering is held in context and it's not the only thing that we're responding to, etc. So one way or another, the care at the bedside ultimately is sort of better than the sort of dogma would suggest. But there's a lot of tension there. This is an important point.
What if a palliative care physician said to the patient, this is a patient with decision-making capacity still, I can relieve your suffering. I know how to use morphine. We can provide it to you in graduated doses, or I can use proportionate sedation, whatever the means be, and you won't suffer. And the patient says, okay, doc, I still want to die.
Yeah. I mean, this is where, I'm sorry, Paul, were you about to say something?
And the physician then, I've seen one case in my life where the physician's feathers are ruffled
Mhm. Mhm.
because the physician is convinced that the suffering can be relieved.
Mhm.
And yet the patient didn't take that gift.
Yeah. So good.
Refused, you refuse the gift of the palliative care doc.
Yeah. Well, and you're naming, sorry, I'm getting excited by what you're saying. Were you gonna say more?
No, go
No.
ahead.
Um, well, so I'm laughing because I see this play out, and this is, I think, a moment of projection where we doctors end up projecting what we think should happen for this person, or more to the point, like, hey, I've got this shiny this tool to work on you, this morphine or whatever it is. This is what I have to offer. Why are you rejecting my gift, my offering? It's like there's ego in that, there's projection in that. Um, but in this way, I think our field, this is where there's a lot of courage in this work, that you don't fall back on dogma and just sort of pat overly simplified definitions of suffering or anything else. This is where I also love the sort of existential frame. If my patients tell me that something is meaningful, whether it's suffering or anything else, but it's meaningful to my patient, I'm going to take that extremely seriously. And then it's on me to reflect, can I faithfully participate in this meaning making exercise for someone? There are limits to what I can do. It's okay for me to say, I've thought about it and I just can't participate in this. That's why I've said, then the next sentence is, but I'm going to help you find someone who can. Like it's important for us providers to be realistic about our own limitations and not overextend ourselves, because then we end up being ingenuinely involved with people. So anyway, I do think, let me bring this point home a little differently. I've been involved with several cases where my patients have hastened their own deaths through the End of Life Options Act. And to a person, as I'm going down my dutiful job of making sure their request to hasten their death is durable, it's not being pressured from external forces, it's not due to untreated pain or depression, etc. So I go down my list to make sure, if I'm watching how it's set up, my job is to make sure their suffering, A, is not amenable to other treatments, or B, is intractable, that I have nothing more to offer. And as a last resort, I can sanction their death and help them off the planet. That's how it's set up as a provider. That's the way I'm supposed to do it. But that's not really how it plays out. Every case I've been involved in, they bring up what you're bringing up. These folks weren't really suffering. They were telling me that this was a meaningful way for them to close out their lives, a last act of their will. It was a way for them to bring their life to a close in a way that was meaningful to them. That wasn't a flight from suffering. They knew the game, so we'd go into theater where they'd have to somehow chart that they're miserable, but they weren't even miserable. They're saying, look, I'm not suffering, but I want to do this because it's meaningful to me. It's important to me. Can you help? And so I walked into those situations, and I did complete the task, not because they were miserable or suffering, but because they demonstrated to me in a clear relational way that this was a meaningful, durable request. And it was my honor and privilege to participate in it in that way. Would that meet the letter of the law? How would that hold up in a court of law? Or does that really meet the regulations? I'm not so sure.
In some states, it would.
Yeah.
It would be. I think I'm not a lawyer, but well, uh, again, I applaud you for. I think your very sensitive discernment here and your wider conception of what palliative care is about. It is not just about the relief of suffering, although it must first try to make all suffering that can be alleviated, so that the patient who decides that, well, now's the time, I'm going to end things by refusing life-saving treatment or by some more active lethal means or by stopping eating,
Mm-hmm.
that patient is not doing it because of their fear of suffering or their current experience of suffering that can be alleviated by good palliative care.
Mm-hmm.
That's your mission in this package. And in that sense, I think it's a very high mission, the
Mm.
alleviation of suffering. And it leads to greater autonomy of the patient, greater freedom of choice, that they're not being, quote, forced into this by a mistaken perception that their suffering can't be alleviated,
Mm.
because maybe it can be due
Right
to
on.
the talents of youth palliative care nurses and physicians.
Yep.
But it seems to me that you're distinguishing things very appropriately here.
Thank you. It
I
is.
no further really critical examination on that score. There is another question though. What if a person said, "Well, I don't want to burden others, and I know how extreme the burdens to others can be in caring for me if I live another 4 years in this condition,
Yep.
and can I suffer if I'm forced to live and therefore burden others?"
Mhm.
It seems to me that burdening others, burdening my loved ones in ways that I think is unnecessary, and it would be better if I did not do, if I act in such a way that they wouldn't be burdened.
Mm.
Now let's assume also they're not complaining loved ones. They're not people who complain about the burdens. I just know they're burdened by the care they have to continue so lovingly to give me.
Yeah.
They want to give it because they love me, but I
Yeah.
know it's a burden to them also.
Yep.
And now if somebody denies me the right to make the decision to end my life, because that's what I want to avoid, burdening others, isn't that imposing suffering on me? To have to live knowing that I'm burdening the loved ones whom I don't want to burden?
Yeah. There's a lot to talk out there. This is why this work is so not transactional. Like we need to sit, I need to really tease this out with a specific person. Requires a lot of back and forth. It's a little bit like, so part of me wants to say to you, yeah, Paul, yeah, you're right. If you're a burden, that you're right. Requiring care is burdensome. Okay. And then for me, I would like to sort of dig in and say like, okay, this is back to the myth of independence. The fact that we're always needing each other, that is a natural state of reality, So I think it's worthwhile in teasing out the unnecessary suffering, the invented suffering versus the necessary stuff. In this way, one of the ways we tease this out is like, maybe your attitude shifts around being a burden when you realize that everyone's a burden, that all of life there's another way of looking at sort of daily life, and another lens we can look at daily life. And sure, maybe as we get closer to the end or advancing illness or disability, we have a bigger burden, but it's not like it's burden if you're sick and no burden if you're not sick. So sometimes I can get far with patients and families by sort of opening these constructs up like we've been doing and finding more space around it. And people then can sometimes say, well, you know what? Gosh, you're right. Life is a burden, and hey, I took care of my kids and now they're taking care of me, and we can maybe find some perspective so that sense of burden eases. Not always though. Not always though.
Not all.
That's right. And so here again, my job is to help make sure someone's eyes are as wide open as they can be, that they are supported as they can be, that they have a safe place to reflect and to find their own way, rather than me bestowing something on them. I'm here as a reflective, supportive, loving tool so they can figure themselves out. So if after a lot of work together, you say, yeah, I've thought about it, but fine, maybe all of life's a burden, but this is just too much. I don't want to keep doing this. At that point, then I have a much easier time accompanying them into taking action, whatever that may be. But not until I really, really know that person. They really, really are looking, and that I know they're looking inward and taking, yeah. So a lot of work needs to happen before I accede to that.
Good.
Does that make sense, Paul?
That makes every bit of good sense. And it
Okay.
it tells me that some people in palliative care like yourselves have really put these pieces together in very sensitive ways. That is, they haven't just oversimplified their mission and the field by saying it's all about the alleviation of suffering. there are other dimensions. There's also a positive dimension of suffering. So sometimes our mission isn't to try to rail against suffering, but to accept it and deal with it. And there's many dimensions here. Another just label that has intrigued me is vicarious suffering. The people who love me, if they see me suffer, they are suffering in seeing me suffer. We talk about vicarious pleasures. We see somebody else doing something we love, we observe it, and we get a vicarious pleasure out of traveling in a way with them. And some people think of vicarious pleasures as superficial. They're the thin version. They're not the real thing. I think there's a certain sense in which vicarious pleasures are real pleasures and could be, in fact, very strong, deep pleasures. Suffering also is when I see somebody suffer, I suffer. Or is that an inflation? Am I calling attention to my own sensitivity in a self-aggrandizing way when I say, oh, I empathize so much with them that I'm suffering? Should we let this animal of vicarious suffering into our mental world here?
Yeah.
It's both good.
Yep. Yeah, part of me wants to fight, like go to the mat together on this word vicarious, because, maybe on some, I think I have two thoughts. One is that vicarious is probably a misnomer. The more we understand physiology, mirror neurons, that on some level we do actually feel each other's experience. It's part of this outrageous life experience, why things are so wild and so resist our reductive tendencies in medicine, etc. There's another one, like vicarious, like autonomy. There certainly is a difference between you and me, but there's also a lot of interrelationship going on in real time. So I don't know if maybe vicarious is a misnomer, because you are actually experiencing through your mirror neuron network, you are actually experiencing something, that's a sensation. It's not made up. And I think it's a matter of proportion. So to your point of am I by presupposing vicarious suffering, am I sort of aggrandizing my experience, pulling the light onto me? Potentially, depends how you state that, depends how you put that forth. And it's also a matter of proportionality. Whereas like, hey, if you're sitting there bleeding, Paul, I may be, oh gosh, poor Paul, but that's not, I should also be smart enough to not confuse your experience with mine. The mirror neurons are only going to get us so far, and so ultimately I still have to defer to the person actually embodying that experience more than me. It's not that I'm not embodying it. It's just you're embodying it more. Maybe there's a proportionality argument in there somewhere. And it also depends on the clinical encounter therapeutically. Like, why would I, as a patient, as a caregiver or a physician, why am I bringing my own vicarious suffering into the mix at all? Sometimes I hear others trying to really, there may be a narcissistic drive there, or like, hey, what about me? Or there could be all sorts of other things going on there. So I just, checking one's intentions, like why are you bringing this up? I think is an important question too.
Thank you. I love this discussion.
Me too, man. I feel like I can talk to you, Paul, for a couple of days nonstop. It is such a pleasure. Do we have more time, guys? Let's see. I haven't even checked out.
No, I think we should go to participants now, or attendees.
Thank you both for this incredibly rich discussion. It's been just incredible to watch you discuss. And we have several excellent questions from the audience that I'd love to jump into now.
Great.
Ellen Weeby asks, or she says, many in the disability community believe that assisted dying devalues their lives, ableism. Can you please discuss that issue in the light of recognizing the validity of another person's suffering?
Paul, do you want me to start at that?
Yes. That one? You start.
That's a great point, and so gets at, I think, what part of what Paul and I have been debating. You know, I do worry. Let me just sort of back up. When I started seeing Oregon's Death with Dignity Act and other states trying to take this up, my first blush as a human being, as a disabled person, as a palliative care person, my first response was, this is great. Here's where we're finding a way to honor the autonomy of another human being and to respect their choices and to say, hey, this is your life, your death. My first blush was pretty uncomplicated exuberance for these laws. And then I started thinking, of course, how what the messages policies send and how difficult it is to legislate the experience of an individual versus the collective, and what is our responsibility to one another. So it's a different question to ask, like, do I believe human beings have the right to dictate the moment of their death? That's a different question from, do I owe, as a physician, do I have some responsibility to someone who wants to end their life? It's one thing for me to say, hey, I respect your decision to do whatever you want. It's different to ask me to participate in it. So that's a distinction that has come into this conversation, I think actually makes a difference. But what I'm sort of wrapping around to, back ending into your question, is I do really, this is why I do worry that the signal we send each other, if we're making it really easy to get off the planet, I do worry that we're sending a signal to each other that suffering doesn't have its own value, like we've been describing, that we are accidentally sort of, if one of the biggest reasons people come to the end of, want to hasten their death is this idea of being a burden. Well, have we done everything in society to make help each other out, to make it easy to find and receive care, to give care? Have we made it easy for the experience of a shared reality in this world? Have we done everything we can to make life meaningful and pleasant and tenable for people? So part of me, from a systems point of view, wants to say, keep this law at bay, to keep pressure on us as a society to improve, to get bigger in our thinking, to get bigger in our infrastructure that allows for more people with different levels of ability to function in society. We're this weird part where our technology has outstripped our moral development, so we can help each other stay alive, but that doesn't mean we can find meaningful work or relationships or even get in and out of our apartment or public transport. So we have this. So I'm really torn, I guess, is the way I'm answering your question, is I'm really torn I'm aware of the symbolic problems of this law and what it might do at the systems level as a policy issue. And I'm also aware of the importance of us acknowledging each other's experience and being true to each other's experience. So I am a little bipolar, or I am a little hot and cold on this law, and I'm not sure what the right answer is. Paul?
There is indeed a legitimate fear, in the abstract at least, a legitimate fear that if we expand people's choices in the sense that they are escapes from life that they no longer want, that we will relieve the society and all the rest of us of the responsibility of caring better for people in these conditions so that they don't have the desire to leave, escape. That's a legitimate fear. Now in Oregon, pick just one state where we have pretty ample evidence, palliative care has improved greatly in the state of Oregon because it has legalized aid in dying. Mm-hmm. And one of the reasons, of course, is they put in the law that you were not eligible for aid in dying unless you had been offered state-of-the-art palliative care. Now, assuming that people who are assisting others in gaining these life-ending expanded choices, ability to implement them, are themselves committed to making sure that the person is doing it not because of some suffering or some condition or some confining, this social confinement, disabled, that the person who's assisting the person in hastening death is also committed to alleviating these other conditions. And that the person finally faces a situation where it can't be relieved. These other burdens can't be relieved more. Society is not going to reform more to make everything perfect in their condition, whether it be dementia or any other condition. Then to continue to deny a person their choice, whether it be through an advance directive and careful link of that to the appointed proxy, or whether it be by current capacity decision making, gets us back to the respecting the patient overall. So there is a delicate balance here. There's one argument that people who oppose legalizing active aid in dying make that I think is simply blatantly wrong. It's that if we legalize a person's choice to end life because they think it's more burdensome than it's worth, that we are sending the message that people ought to make that choice. But in a liberty-respecting society, people are all frequently, of course, they're given the liberty to make decisions that society is not saying are the right decisions. Because liberty is the right to make the decisions that you think are best, not because the society thinks they're best. And society shouldn't impose conceptions of what you ought to decide. It's not respecting your liberty if it does impose those preconceptions of what the right choice is. So we deal with this conflict all the time. We respect liberty, even though we don't impose a particular, we don't say that the way you use your liberty is the way people have to use it. Mm-hmm. We're not saying you should die because we give you the liberty of choice to die. Mm-hmm. We're not saying you should speak when we give you the free speech, right to free speech. Mm-hmm. Don't make you speak. Mm-hmm. This distinction is fundamental to a liberty-respecting society. Mm-hmm. If it's so fundamental, then why do we not see the relevance of that distinction when it comes to aid and dying? So the argument that legalizing is justifying the decision is just flat out wrong. Mm-hmm. It's a bad argument. People don't understand the social and political fabric of our society if they make that. Mm-hmm. Now, I'm not saying all the arguments against active aid and dying are bad arguments, but I think that one, that by making it legal, we're endorsing it as a society. You're not endorsing it as a society because we say people ought to be at liberty to choose. Mm-hmm.
Thank you, Paul. Thank you, BJ. Let's move on to our next question from Ben Sarby. He asks, in your definition of palliative care, you called it a, quote, family and patient-centered practice. Mm-hmm. Do you think that the primary purpose is to aid the patient, or does a palliative care team owe an equal responsibility to the family and loved ones? Your thoughts?
Well, I think I'd get tripped up if we're around the axis if it's equal. You know, I think I suppose if I had to force it, I would say that the patient's experience sort of still trumps, and I respect the family's role in that insofar as the family impacts the patient. That's one way of looking at it. And so when there's distress in a family member wants one thing, the patient wants another. If we're really at loggerheads, and it's really usually, it's usually what feels like a split in the family can usually be addressed with more communication, more support, more listening. And almost always those splits can be reconciled. But if they can't be reconciled, and if I'm forced to choose, I suppose, of course, I would support the patient's wishes over the family's. But those are that's splitting hairs. We rarely need to come to that. So my answer to your question is, I don't usually need to make that distinction, and rarely do. And if I do, the patient would trump. But otherwise, if I'm taking your question a little bit differently, I think another way I might hear your question is the experience of the patient and the family and the friends, their circle of friends, family by choice or by blood, Is that important? You bet it is. Is it critical? You bet it is. So an easy answer to the question is yes, the experience of everybody involved in this person is essential to me as a palliative care provider. If the question gets at like if one trumps the other, then ultimately it's the patient, if I'm taking your question right.
Thank
Paul, would
you.
you change anything on that one? Paul, I love listening to Paul, so sorry.
No,
Would you
I have
change
no further comment. I would say only what you said.
Okay.
Wonderful. All right. Our next question is from Guy Perrier. He says, we have heard about suffering from a patient's perspective. If the unit of care is extended to other people that may also be present at the bedside, what does the panel think? In many contexts, the person who is dying may not be able to exercise their own autonomy if unable to communicate. Their quote unquote suffering can manifest through their family. So this is getting back to your point, BJ, about unpacking the sense of autonomy.
Mm-hmm.
What are your thoughts?
Well, I confess I missed the question in there, Sarah. Can you read it again?
So I actually thought there was a question at the end, but I think he's asking, what do you as the panelists think about of suffering affecting the family at the bedside? If the unit of care is extended from the patient's perspective to everyone around them, not just the family, but also the care team.
Mm-hmm. Well, I definitely think I have come to almost, I kind of wish the unit of care were extended to say patient, family, friends, care team. I think we've been seeing the problems with this sort of pathological altruism model of healthcare where I, as a physician, don't see relevancy to the exchange, like my own well-being, my health, my own thinking, my feelings. If I don't see those as relevant to the therapeutic exchange, a therapeutic relationship, well, it's not a relationship at that point. If I, as a physician, take it on that my job is to not have feelings, not have thoughts or feelings of my own here, I'm totally there to care for the patient, then I'm missing out on a lot of signals that my body and mind would be telling me, because a lot of these things are figured out in relationship. And if I ignore my piece, or the care team ignores their piece of that puzzle, not only does that suck for the caregiver, but ultimately that lends itself to bad care. That's where you get burned out providers, and burned out providers generally don't do a great job at the bedside.
Thank you. Paul, any thoughts?
Well, certainly I endorse everything I agree with everything that BJ said. Sometimes there are conflicts, and I believe these are probably can be accommodated in the view you just stated. But to take one example, because I've been working on voluntarily stopping eating and drinking as a way of hastening, as an option for hastening death. Not something we should ever say people should do, but as an option that should be, they should be made aware of as a viable option. That is an option that can be made relatively peaceful and relatively painless. Now, the usual conception of dying by starvation and dehydration is that it's terrible. Mm-hmm. But we know very much by experience that hunger pains virtually disappear after 48 hours as the stomach shrinks and just stops. It just gets used to no food. I've had this experience myself. I actually was on a hunger strike for 10 days. Political, many decades ago, and the group of people I was with and doing it, one of them was experienced with this and said, "You won't even be hungry after 72 hours." Amazingly, and it isn't just because we wanted to agree with him, we weren't. Thirst was the problem. So then the question in voluntarily stopping eating and drinking is, can you alleviate the thirst? Well, good palliative care physicians experienced in such cases know that thirst can be alleviated a lot. Not completely, because there still is dry mouth and a very distinct discomfort. But there are a variety of ways by which palliative care physicians, I owe this to conversation, can alleviate the discomfort from thirst, which is the bigger problem. It's relatively alleviated enough that the person who still knows what they're doing, they're still refusing to eat and drink because they want to hasten their death, given the circumstances overall. They're not backing off their decision. They're not so thirsty that they've changed their mind on stopping eating and drinking as the way to hasten their death. They plow on with it. Mm. But the family member says, or some caregivers will say, this is intolerable. They're suffering. So caring for the family in that case should be, I think, just getting them to see that the patient's view probably correct. That this is manageable suffering that they're willing to go through. But if the family says, well, oh, they can't suffer at all, they shouldn't be made to suffer at all, we have to make them drink. I think they're just making not only suffering, but they're making their perception of suffering into the guiding criterion here. And neither should suffering be the necessarily dominant consideration, nor should anybody else's conception of the patient's suffering be dominant. So, end of the matter.
Yeah.
Thank
you
you.
reminded me, Paul, can I just jump in again? You reminded me to kind of tail back to what we've been talking about otherwise too, which is just to name that as a provider or as a family member, as just a human being on this planet, yes, I think we can and should ferret out suffering where we see it as a general rule. But I would say, so half of our energies perhaps could go that way, but the other half should be learning how to sit with suffering. How do we sit with things that we can't change? That is its own life skill that should be folded into this work too. Otherwise, we're chasing perceptions and projections. So anyway, yes, right alongside of the skill set of ferreting out suffering should be the skill set of actually tolerating it when we can't change it.
Thank you. So piggybacking off of what you just said, BJ, Stephanie Green asks, while meaninglessness may be inevitable and acceptable and normal and important to acknowledge, does a sustained state of meaninglessness not cause potential harm to some individuals? Do you believe a state of ongoing meaninglessness can always be addressed? Do you believe there may come a time when meaninglessness may overshadow the bigger picture and accept that this might lead to an autonomous decision to end life? Suffering may be a teacher. Is that meaningless? Is that meaningful?
Oh boy, every time we pick a single fulcrum, we're going to find problems, right? Suffering, we beat that up as a singular fulcrum. And I hear myself sort of latching onto meaning as a bigger, better one, but that too is going to have its limitations. So this is one of my favorite things about this big subject of death is it just mercilessly obliterates our reductive tendencies. It just will not tolerate it. Every time we think we got a hand on it, there's an exception to the rule. And it's just the wisdom of not confusing our models and constructs with the reality those things are trying to help us digest is really, really key. So that's all preface to answer this question. I mean, here again, if that question is to me as a palliative care physician or a family member or a friend, accompanying someone who just can't find meaning in their life, and I've experienced that for various periods of time, and I have learned to accept that because I in that place, if I can't find meaning, well, then I can find curiosity, I can find wonder, I can find other things, but that's me so far. I'm 50. Who knows? Will I continue to be able to do that and end my runs of meaninglessness in some way? I don't know. But just like everything else we're saying here, if my job, if someone's coming to me to hasten their death out of a sort of a meaningless existence, well, it's on me, if I'm going to participate in that, to dig into a relationship and really talk that out, explore together. What's the difference between finding meaning versus manufacturing meaning? What's to stop you from making meaning, claiming this is meaningful to you? Even on a small scale, did you feel a little sensation? Just by virtue of having a body that allowed me to feel a sensation makes me like having a body. Okay, then I want to live another minute. I mean, there are so many ways that over the course of a relationship, you can ferret this out. And by providing a real relationship of exchange where I'm genuinely with another person, sharing my vulnerabilities and fears and struggles with meaning too, you know what ends up happening, even if my work can't help them see or find meaning, the relationship itself of where together we're looking for it can become meaningful. So, you know, boy, we can get really convoluted very quickly, but ultimately, just like everything else we're saying, if we go through all that and the person's saying, yeah, I hear what you're saying, but no, it's not working for me, and they still want to hasten their death, you know, that's a different conversation after hours of working on it together versus the first 5 minutes.
Sure, thank you.
People's decisions to hasten death are not largely driven by a sense of meaninglessness. Sometimes, in rare cases, they are so-called existential suffering. In certain cases, maybe there's no meaning in my life anymore. I want it over. Those are rare. More often, decisions to hasten death are driven by a sense of meaning. The meaning in my life is that I've had this kind of life. It really meant something to me. I think it meant something to others. But that isn't going on anymore. And I know subjectively, because only I can, you can't speak for me. I need to speak for myself on this. And it would be a more meaningful life if it ended now than if it didn't end. It's going to be a more meaningful life if it's going to be a shorter life. Well, all we have to do is realize that what's being preserved here is a life. And a life is a life over time. It is not a moment in time. Life is not a moment in time. A life is the thing we prize the most. Our lives, what we prize the most, have temporal extension. And that means that you can find meaning precisely because of your sense of the meaning of your life. You might decide to hasten death. And when family doesn't understand that, problems are created. When caregivers don't understand that, problems are created. And sometimes when the patient is not enabled to understand that, sometimes they need some help to see that meaning. Although we don't want to talk them into it. That's the other danger. We don't want to talk them into viewing their life as more meaningful if they die now. Mm-hmm. No, they have to make that decision.
Mm-hmm.
Thank you. We have time for one more deep dive into a last question here before we conclude for today. The question is from Mark Peterson. He says, with regard to the issue of dementia, how do we understand which person I am dealing with when I am working with a person who wants to die rather than continue living in a diminished state? The clearly competent one who wrote a dementia directive, or the one who is no longer competent?
So if I'm taking that, did I hear the question right? So in a way, would the word of someone who is in the throes of dementia, but demonstrating or telling me that they are suffering, that they are unhappy, is that compared with the directive in advance from someone who has all their faculties? If I'm hearing the question right, it's a real good one. I mean, our job is, yes, we are temporal creatures and we move through time together. And if someone, you know, boy, I don't know exactly how to approach that question, because legally, the word of someone who does not have capacity, we take with a huge grain of salt. So if someone who's in the throes of dementia tells me that they're unhappy, well, I might find myself saying, well, let's wait another couple minutes and see, that they're in this constantly in the moment state, and that moment may change. And do I give it time to change? Well, here again, So I hear myself, you might become, this question may get at the limits that I've explored the legalities here, because just like providers can hide behind this mantle of suffering, we can hide behind, oh, well, sorry, you don't have capacity. I can't take what you say seriously. And I don't want to do that here. But I don't know what I would do. I know I legally couldn't accede to the wishes of helping hasten someone's death if they are floridly demented. So I would probably hide behind that law and try to figure things out. But here again, Paul, I'd love to hear what your response to that question is.
I've gotten in trouble from both sides from what I articulated in writing, which is that the so-called then self, now self problem is a real problem. The then self, the person who wrote the directive, the now self, in the case of dementia, the person who's now, let us say, one of the contented dement. Does the word of the then self who wrote the directive saying when they should be allowed to die by refusing life-saving treatment, withholding life-saving treatment, or by withholding assisted feeding, is that word of the then self to be taken? It's the directive is sufficiently clear. It's being interpreted by the proxy they had great faith in, et cetera, et cetera. All the pieces are in place to be able to implement that directive, even though they appear to be contented now. The now patient is contented. The now person. There's a conflict. But at a certain point, we have to ask, what is the value of the life of the now patient, now person, to that person? And as dementia gets more and more severe, although some people bristle at what I say here, object to it greatly, when a person can no longer anticipate tomorrow, and when they get to tomorrow, they can no longer remember yesterday, what appreciation of survival, of their own survival, do they have? They still have an appreciation of being alive at the moment. It's the eternal present. But when I think about my life, why would I not want to die now? It's because I can anticipate tomorrow. I get to tomorrow and I'm grateful for having survived. What am I grateful for? It's having survived from yesterday, when I anticipated that I would have it tomorrow and wanted to be alive. You have to put all these time perspective things together to get robust desire or value for life. Yes, the person who can't do that anymore because they don't have the capacity to anticipate tomorrow, or when they get to tomorrow, remember yesterday. That person still has a capacity to appreciate the moment. But how great is that? And how great is it in proportion to a very clear, strong advance directive they wrote that now is the time to call it? It seems to me that at a certain point, the balance shifts to respecting the directive. Why? Because it's their life. Life gets defined by them and isn't just defined by the person who can't see the life anymore. Now that's controversial, but I want to hold the tension. I want to keep the tension, but I want to say that at a certain point, the time is right to follow the directive.
But did we take the question right, though? And sort of the situation is in reverse, that if the person didn't write an advance directive, and as when they were, the then person didn't write an advance directive that helped us out, and the now person is demonstrating misery and saying they want to die. Is that the more the nature of this person's questions? What do we do in those situations? And does your answer change, Paul, with that dynamic shift? In other words, what do you do with a now person who's demented, who's obviously miserable and asking to die, even if they don't have?
Well, if their autonomy isn't in play anymore, well, they don't have. They have to distinguish different senses in which they have capacity to speak. They don't understand what their directive was. They don't understand enough to be able to or revise the one that they did write. They're not even aware they wrote one.
Hmm.
So they don't have decision-making competency for any of that.
Right.
But are they competent? Do they have decision-making capacity to say, I'm suffering? Yes.
Yeah.
So capacity comes in a huge range of degrees. And on the question of suffering, yes. As long as we're pretty sure that their behavioral indications that they're suffering are real indications that they're suffering.
Yeah.
We have to take their capacity to express their suffering really seriously.
Mm-hmm. Right on. And where this gets tricky, I guess, is we want to treat capacity in the sort of medical legal sense of whether you either have it or you don't. It's another one of those versions that we treat as a sort of a single fulcrum, which is in fact a huge spectrum. And that's a sort of general tension in everything we've been discussing today. And one of the ways we make mistakes, we call spectral things dichotomous variables. In fact, when they're all on the spectrum, this is a classic mistake we make because it's just easier. We like dichotomous variables.
But in fact, you're on legally shaky ground if you say there's only one definition of capacity.
Mm-hmm.
Capacity is relevant to what you are making a decision about.
Right on.
I mean, that's legally true.
Yeah.
Also. Although there are certain contexts in which that legal definition is more simplistic.
Yeah. So you're right on. So it does the law does allow for some shading of gray. Not what I wouldn't say the full spectrum, but there are at least there is something besides a dichotomy there. Yeah. With you. Woo, fascinating stuff. We humans are.
Well, BJ, Paul, it's been a tremendous honor to sit with you virtually today and welcome you to the space and have you both in dialogue and conversation. I feel like we've been whisked around the universe, around the globe at least, diving into these really deep issues. So thank you. Immense gratitude from everyone at the Completed Life Initiative to both of you for being here today. And thank you so much for everyone in the audience who's attended today. It's been wonderful to have you here and to have your questions come in. And I just want to make a brief plug for Mental Health, which is the healthcare organization that Dr. BJ Miller co-founded and directs. It's an incredible foundation that addresses physical, social, spiritual, emotional needs of anyone contemplating the health of themselves or someone they love. So I'll share my screen to show you
Thanks,
the
Sarah.
website.
By the way, that is a safe place. Mental health is a safe venue to come have these kinds of conversations, by the way, and we do.
So here's the link to their website, mentalhealth.com. So please check them out. They're a partner organization to the Completed Life Initiative, and we're just so excited to be your friend. So thank you. Please don't forget to check out our Completed Life website, completedlife.org, for more info on everything we're doing. And please, let's see, there was a slide here. There we go. Don't forget to tune back later today for session 2 at 5 p.m. Eastern, 2 p.m. Pacific, for session 2 of Unprecedented Understanding Multifaceted Suffering. And we'll be joined by panelists Linda Golding and psychiatrist Brent Cayuse. So looking forward to welcoming you back later today. Again, thank you so much for joining us for the Completed Life March Symposium, and we'll see you soon. Thank you so much, and be well.
Thank you.
Thank you.